Hello, my name is Natalie Crawford, and I am an assistant professor in the Department of Behavioral, Social, and Health Education Sciences in the Rollins School of Public Health. Today, I will be discussing pharmacy-based approaches to improving substance use-related harms in HIV in high-risk communities. Just as a brief outline, first I want to discuss the epidemiology of HIV by race and ethnicity, followed by a discussion of the epidemiology of sex and substance use risk behaviors by race and ethnicity. And then I really want to get into some of my pharmacy work that works to reduce racial and ethnic inequities in HIV. So first, I think we can all agree that racial and ethnic inequities in HIV exist. There has been data consistently for decades that shows that Black Americans have a higher rate of HIV diagnosis compared to our white and Latino counterparts. And two of the main ways that HIV is transmitted is sex without a condom and through injection drug use. And those are the two ways that most of my work has really focused on. So for people who inject drugs, in 2010, there were stark racial inequities among both Black men and Black women compared to white and Latino populations. Given the opioid crisis and racial inequities in HIV among people who inject drugs has declined. However, among Black men, they are still persistent. Among men who have sex with men, racial inequities persist mostly among young Black men who have sex with men compared to white men who have sex with men, and declines as the population ages. Unfortunately, what has been very difficult for the field that has tried to improve and reduce HIV morbidity among people who inject drugs and among men who have sex with men is that we've had a difficult time understanding how these inequities persist despite behaviors that don't explain these disparities. For example, condom use among both Black and Latino men and women is lower than that, is higher than that of white women and men. The proportion of people who inject drugs is they're less likely to be racial minorities, as you can see. The proportion of people who inject drugs is highest among white Americans compared to Black and Latino Americans. And when we look at behaviors within injection drug use, Latino and white people who inject drugs are more likely to receptively share syringes. And so risk behaviors are often, riskier when among white populations compared to racial minority populations. So we've done a lot of individual level interventions, and in these interventions, we have been able to see quite a bit of success. We've seen that providing clean, sterile syringes reduces HIV. We have seen a number of things that condom distribution is able to increase safe sex. However, a lot of times these interventions are successful at the time, but their effects are not always sustainable. And we still can see unequal distributions of these interventions by race, which may further racial inequities in health outcomes, specifically HIV. And so we see that syringe access, it can be disproportionately distributed more in neighborhoods that are easily accessible to whites. We also have overwhelming evidence that, for example, pre-exposure prophylaxis, which is the drug that is used to prevent HIV, a daily oral PrEP dosage prevents about 96% of transmission for HIV. We are able to see that there are huge racial inequities in uptake of PrEP that further racial inequities in HIV. And so while these individual level behavioral interventions are really positive, and our biomedical interventions such as PrEP are really positive and can really make a strong impact in reducing HIV, they are implemented within systematic within systems and structures that continue to stratify access by race and therefore disadvantage racial minorities and further racial inequities in health. And so what we really need to help reduce racial inequities in health are structural interventions. And these are interventions that target the economic, social, contextual policy factors that have an increased risk or can protect against HIV. And so if we are able to implement these same interventions within the structural systems that then don't recreate or perpetuate inequities by race, then we are actually able to make headway to reduce inequities. And so all of my work around structural interventions has really been within pharmacies, using pharmacies as a way to increase access specifically for racial minority populations. And so the question it's been asked is, what is the role of pharmacies in HIV? So historically, what we think of as pharmacies' role in health in general is as a way to dispense medication. And so this is no different for HIV. We generally think of pharmacists as the point for where we are able to access antiretroviral therapy for people who have already become or who have already become HIV positive. But there is another way to think about the role of pharmacies in HIV prevention as well. So for example, this is a map that shows the states that have authorized deregulation of syringe sales in pharmacies. And so the states in blue indicate that there is some authorization in that state to allow the retail sale of syringes for people who inject drugs. One of the first states that did this was New York, and I was very fortunate to have the opportunity to work in New York at the time to be able to help understand the impact of deregulation of syringe sales in pharmacies and how that might help the population of people who inject drugs. And so now I want to really move and shift to discuss some of that work. So one of the first programs that evaluated deregulation of syringe sales was performed by the New York Academy of Medicine through where they evaluated the ESAP program, which is the Expanded Syringe Access Demonstration Program. And so this was a program implemented as a demonstration project in 2001 by New York City's Department of Health. And so they wanted to really see whether or not deregulating syringe sales could improve access to syringes, improve safe syringe use. And overall, the program was a huge success. They were able to show this increased access, but they were also able to show that this did not increase substance use, which was obviously a lot of the critics' main concern, is that, which happens a lot in structural interventions. They say you give people more access, people use more. Well, that was not true. One of the main caveats of this program at the time when it was implemented was that it was not reaching Black and Latino people who injected drugs, which is a problem because it can further inequities. And so what we began to work on and the next pilot study was to figure out a way where we could increase access, specifically in Black and Latino neighborhoods. And we did this by a community level intervention of increasing awareness about substance use and educating pharmacies, educating the community, and informing people of the ESAP program and letting them know that this access was available. And this program, this study was also very successful. Among all people who injected drugs, there was a 100% increase in safe syringe use that went from 13 to 32%, but specifically among Black people who injected drugs, there was a 300% increase in safe syringe use that started as low as 5%, but increased to 22% in a short period of time. One of the key things that we learned from this was that pharmacies were really happy. Pharmacies in minority communities, racial minority communities, were really happy about their ability to help a population that had been marginalized and disadvantaged. And they wanted to do more. And so we then built on this program by implementing another pilot study called the PAT-LINK study. And in this study, we essentially trained pharmacy staff how to engage with their customers who came in to buy a syringe without a prescription. And we We taught them how to provide social and medical service referrals. And this was a complete success as well. We were able to link most of the population who came in with additional referrals. And we also learned again that pharmacies wanted to do more. And so in that process, we began to say, okay, well, why don't we test this more rigorously? So we designed a community-based randomized pharmacy intervention and enrolled 88 pharmacies across New York to reduce the negative effects of injecting drugs among people who inject. And all of this work was guided by a working group of advisory members, community members, people who worked at the Department of Health, who were leaders in community-based organizations. And so this study started by us doing a canvassing of of New York City to see who was eligible to participate in the study. So in order to be eligible, you had to have registered to be able to sell syringes without a prescription through the ESAP program. You had to have at least one ESAP customer per month, one new customer that became regular, and you could not ask your customers for any additional information when they bought syringes. And that was a part of the ESAP program. You couldn't ask them to sign any book. You couldn't ask them to give their name or see their ID. And so as we sort of canvassed New York City to make sure that pharmacies knew about ESAP, we determined eligibility and we excluded a number of participants and a number of pharmacies, and about 130 pharmacies were willing to complete a baseline survey with us. Then among those, we wanted to recruit them into an intervention study, and 88 of those pharmacies were willing to be randomized into one of three groups: an intervention group, a primary control group, or a secondary control group. In the intervention, what we wanted to do was train the pharmacy staff on harm reduction strategies for their ESAP customers. We provided in-pharmacy one-on-one trainings. We also brought them to the New York Academy of Medicine and did in-person continuing education certified programs that would help them understand how to engage and expand services to people who injected drugs. We also asked them to recruit their ESAP customers into an additional study for us. And we surveyed them at baseline, 6 months, and 12 months. The primary control group was also trained with just one in-pharmacy training. And we also surveyed them at 6 months and 12 months, but that one training was a little less rigorous. We were really just teaching them how to ask their ESAP customers to be in our study. So we did not give them the additional harm reduction training because we wanted to see the effect of ESAP customers who received that additional harm reduction, those harm reduction services from their pharmacy staff versus ESAP customers who didn't. And then finally, our secondary control group, we did not do any training with at all. We wanted to be able to compare pharmacy staff who had literally a lot of interaction with us because they were helping us recruit their ESAP customers with pharmacy staff who didn't have very much interaction with us. And so we just did baseline 6 and 12-month interviews with this population. So what we were able to see over a year follow-up is that pharmacy staff who were in our intervention or primary control group were significantly more likely to support providing syringe services to people who injected drugs through the pharmacy over time. And so this is denoted by this top graph, and you can see the green and the red lines are significantly different from the secondary control group, this purple line. And so these findings remained after we adjusted for various characteristics, and you can see that by model 3, they were about people in the intervention group were about 27% more likely to support expanded syringe access compared to the secondary control group. So we also asked pharmacies in the intervention and primary control groups to recruit their ESAP syringe customers for us. And so this data just shows that our pharmacies did quite a bit of work in those efforts. In the intervention group, they made over 500 appointments. In the primary control group, they made over 900 appointments. And both of them had about 77 to 80% of people who were willing to enroll in our survey. And there were really high levels of follow-up for the participants. We interviewed them at baseline and at a 3-month follow-up, and we were really floored by how willing participants were with coming back, because it is oftentimes very difficult with populations who use substances to achieve high follow-up rates. And so what we were able to see among our participants who went to our intervention pharmacy, we were able to see much better risk behaviors, much lower risk behaviors than our participants who went to our control pharmacy, where the pharmacy staff did not have harm reduction training. So in the intervention pharmacy, participants who went to that pharmacy were less likely to receptively share syringes. They were more likely to use pharmacies as their primary syringe source. They were more likely to have 100% sterile syringe use, and less likely to perceive pharmacy syringe purchasing barriers. And so we thought this was really, really positive. And we were really able to begin to realize from a rigorous study how pharmacy-based public health services could have important impacts on health and health behaviors and transform delivery of preventive services in healthcare. The other thing that we kept hearing from our pharmacy staff, again, was that they wanted to do more. So we thought, well, let's try to offer HIV testing for this population within pharmacies. So we recruited 2 pharmacies in Harlem, and we offered HIV testing. We were specifically setting out to do this for people who came in to purchase a syringe without a prescription, so people who injected drugs. And what we saw when we started this study was an overwhelming level of support, where people who were not necessarily ESAP customers were coming in and saying, hey, we heard that you guys are offering this, we wanted this, and so we want to do this anyway. And so we had to figure out how to offer those services even to people who were not ESAP customers. In the data, what we found was that we were able to reach people at high risk for HIV transmission. So racial minorities, people who use drugs, people who had not been recently HIV tested for HIV, and people who lacked a regular source of care. But there was still only 40% of HIV testing uptake among people who took our survey, and we thought, well, that's really not high enough. And so we began to understand that HIV testing stigma was really playing an important part in this, and so it was the culmination of both lower access, also with people who had some externalized and internalized stigmatizing beliefs about HIV. And so we thought, well, there may be a way for us to reduce stigma through offering HIV testing in neutralized pharmacy settings. So oftentimes people go into pharmacies for a number of health services, primary prevention services. And so we wanted to increase HIV testing access in the pharmacy, but we also wanted to normalize HIV and HIV testing in the pharmacy and through using media messages. And so we did this in 2 ways. So we recruited 3 pharmacies. One was a pharmacy that offered comprehensive services. And so that included HIV testing services. We created a video that promoted HIV as just about your regular health, not necessarily your sexual health. It was akin to receiving your chronic disease screenings, like your blood pressure screening. And then we also offered those additional chronic disease screenings in the pharmacy. Then we just had a video arm because we wanted to be able to compare whether or not having the comprehensive screening package mattered or not. And so in this video arm, we just offered HIV testing, and we just tried to normalize HIV testing through the video. And then finally, we had a control arm where we just offered HIV testing alone so that we could compare the video effect. And so what we were able to see here is that both the video and the comprehensive screening arm significantly increased the likelihood of testing for HIV. And this is specifically These data are specifically among the population in our sample who reported that they had HIV, shame, or blame. And so that was really important for us. So this is specifically among the people who did report some levels of HIV testing stigma. We were able to increase their HIV, their willingness, their testing, HIV testing by 60%. So we learned that pharmacies can help with increasing access, and we could wrap HIV testing into these existing services to reduce HIV testing specific stigma, normalize HIV testing, and reduce the idea that HIV is a disease that's so different from other diseases. The other thing we still learned was that pharmacists wanted to do more. And so that brings me to some of my current work, which has really been in the PrEP space. We've recently been doing a lot of work to try to develop a model of PrEP screening and delivery in pharmacies, specifically in Georgia. And so in Georgia, we've been doing a lot of preliminary screening to better understand who would be receptive to PrEP screening services in pharmacies and who's supportive of this. And so in collaboration with the Georgia Department of Public Health, we asked some questions about this at Black Pride. And in this data, we were able to see that over 69% of men who have sex with men were willing to discuss PrEP in a pharmacy. 60% were willing to be screened for PrEP in a pharmacy. And the only significant correlate of willingness to screen or discuss PrEP was whether or not people were interested in PrEP. It was not, race was not even important. So this which could show that if we could equally reach both Black, white, and Latino users, Black, white, and Latino men who have sex with men in a pharmacy, not determined by their race, which would hopefully not further inequities. We went on to further do some qualitative interviews with both pharmacy staff and men who have sex with men to better understand their support and actually how a PrEP screening, a pharmacy-based PrEP screening and delivery model might work. And so what we learned from both key stakeholder groups was that there was very strong support for in-pharmacy PrEP screening and delivery, but two things were really stuck out as being really important. For men who have sex with men, privacy and confidentiality were paramount, which is completely understandable. And for pharmacy staff, training for the pharmacists to be able to implement these services was also paramount. So I want to conclude by just saying that all of this work is really growing to show that pharmacies are viable solutions for reducing HIV and substance use related harms. Pharmacy-based HIV and substance use interventions could possibly increase access for racial minority populations, thereby reducing racial inequities in HIV. And there are some special considerations that we are going to have to take as we consider how to continue these efforts within the COVID era, and also how we consider how to scale these pharmacy-based interventions for more pharmacies so that more community pharmacies can take on these practices and have a larger impact in the community. And finally, I just want to close with saying that pharmacies, we should work to better harness pharmacy-based populations to better understand also substance use and HIV risk behaviors, because this might be a population that we have not tapped into as much, and could give us a wider understanding of both of these epidemics. I want to thank you for your time and acknowledge all of my collaborators across a number of institutions and my funding sources.